Hi, this is Elliot Fishman, and welcome to our latest talk. And this is going to be a little bit of an unusual talk. It's evaluation of the large adrenal mass. Some people say a large mass is 4 cm, some people say 5 cm, but I guess we have to stick with 4 since some of the referring articles basically focus on 4. You remember that typically when we think about adrenal adenomas or incidental adrenal lesions that we think are adenomas, we always say that the rules of washout only extend to a lesion up to 4 centimeters. Remember, in the past, it used to be 3 cm. Most people agree 4 cm. So the question is, how do we deal with these large adrenal masses? Who do we follow? Who do we biopsy? And who do we resect? Well, if you have a differential diagnosis list, this is not all of them, but you can see adrenal masses over 4 cm basically are everything from adenomas to hematomas to benign lesions like myelolipomas or simple cysts to pheochromocytomas to malignancies, be it an adrenal cortical carcinoma or perhaps metastasis, lymphoma, or unusual sarcomas. Essentially, almost anything can be over 4 centimeters. The challenge with a large adrenal mass are several. First of all, biopsy in most cases is not considered an option. Our surgeons will make the point, if you're thinking it could be an ACC, do not biopsy the lesion. Once you biopsy the lesion, the capsule is then broken and you will see the tumor. So biopsy is not a very good consideration. Also, most recently, there was an article that even when you do biopsy, most of the time you don't get a prominent or definite diagnosis. The other thing is that imaging must make the diagnosis or at least help you predict benign from malignant. And that's because if you want to do surgery, forgetting following, if you want to do surgery, if you think the lesion's benign, then you'll do it as a laparoscopic approach. If you think it's malignant, you'll do an open approach. Why does this matter? Well, recovery for a laparoscopic adrenalectomy is usually about a day or so. A open approach is 7 days with significant complication rates, patient discomfort, and the like. Now, lab values can be helpful. Think about a pheochromocytoma for a second, but often they're not really that helpful. In this article by YIP, American Association of Endocrine Surgeons, Guidelines for Adrenalectomy, you can see in their executive summary, they make the point that features in addition to size should be considered when assessing risk of either a primary or secondary malignancy in an incidental adrenal lesion. So you can see it's really hard because the idea about doing a biopsy is something really not one of your basic things you keep in your pocket. Remember, you see a pancreatic mass, you're not certain what it is. Even if you think it's probably going to be a serous cystadenoma, you'll say that, but they'll still probably do EUS and biopsy. Yes, with a liver lesion, you may do MR, and that may be helpful, or you'll end up doing a biopsy. With adrenals, you're going to end up with a lot of these lesions. Well, it could be this, or it could be that. I think it's probably benign, but it's a lot of times, and the more time I spend at adrenal conference, more and more of these uncertain lesions appear. We had conference just this past Friday. We do it every other Friday. And out of the 8 cases, now obviously the cases that come to conference are the more difficult cases, but there were 2 cases I think I know what the answer is, but I'm not 100% certain. And they were both lesions well over 4 centimeters in size. So it's not going to be simple. Now, the flip thing I want to mention, and I want to reinforce, is just because a lesion is small doesn't mean it's going to be benign. Again, that 4 cm looks like an adenoma, incidental finding, just don't worry about it. But this patient had this incidental nodule, right adrenal, it's a little over a centimeter. It looks all the world like an adenoma, but if you measure it, it doesn't measure under 10. Patient had hypertension. So it's very important when we look at incidental adrenal lesions to really look at the history. Is the patient hypertensive? Is the patient cushingoid? What exactly is going on? Well, in this case, you can see that lesion. It's small. In your heart, you know it's a benign lesion. You measure it when you give contrast. At the venous phase, it's 101 Hounsfield units, not quite the number we think about Pheo. But there it is. It's a 1 centimeter lesion. You can't call it an adenoma. The patient was worked up for their hypertension, and it ended up they had what was felt to be primary aldosteronism. And this is a common underdiagnosed cause of hypertension. The patient and the presentation is classically known to occur in a patient with hypertension and hypokalemia. So it's something you need to think about. One of the reasons people suggest that incidental adrenal lesions can be a way of picking up incidental clinical problems, that it's not just an incidental, but it's an opportunity for making a diagnosis, is aldosteronism with these small lesions, which is so nicely here. And if you look at the causes of primary aldo, it's usually an adenoma, occasionally hyperplasia, which you can tell the difference on CT, of course. You can have occasionally secretion from the kidneys or ovaries, really rare and familiar causes. But right in the middle is adrenal cortical carcinoma. That can be one of its presentations, albeit uncommon, but gosh, in a million years you would not think this is an ACC. Well, the patient had the lesion resected. This was a primary adrenal cortical carcinoma. Wow, that's essentially the smallest lesion I've seen. And again, you could see the clinical. If you ignored the clinical findings and you just went by, you would say, get routine follow-up. This was resected. The patient is cured. Here's another patient. Patient had some facial hair, 22-year-old female. They were doing abdominal CT, and you see an incidental adrenal lesion. It's larger than the last case. On non-contrast, it's about 36 Hounsfield units, but again, maybe it's just a lipid-poor adenoma. When you give contrast, it enhances to 100, and then it washes out to 53. Well-defined. Okay, look at those numbers, 36 to 100 to 53. If you only look at the size of the lesion, it's well-defined, and you look at the washout, you would say, hey, this is classic for a lipid-poor adrenal adenoma. Well, guess what? This patient had symptoms of Cushing's, and guess what? This was a 1 centimeter ACC. Again, 2 examples of cases where small lesions can be malignant. So I just want to emphasize the point that size alone is not going to help you always make the diagnosis. Things that are large and look, oh my goodness, this must be bad, could be benign. And little lesions, 1 to 1.4 centimeters, which you could take to the bank, this must be benign, ends up not being benign. Now, in terms of larger lesions, again, we said 4 cm or better. This article from the Mayo Clinic, prevalence of malignancy in patients with adrenal tumors of 4 cm or more was 31%. So this was their study. They had over 4,000 patients they looked at. Older age, male, non-incidental mode of discovery, larger tumor size, higher non-contrast values, all increased the risk for malignancy. But at the end of the day, less than a third of the lesions were malignant, even though they were larger. And you could see some of the numbers. Underlying diagnoses were adenomas a third of the time, Pheos 22%, other benign tumors 16%, ACC 13%, and other malignant tumors 18%. So you can see that even when you have a big mass, that alone may not be enough because it's 2/3 of the chance it's not going to be a malignancy. So again, we're in a very tough position, and this is why the radiologist is so important. Who needs to be operated on? How do you manage these patients? In that same article by Inguez Aziza, we suggest that clinical context, hormonal assessment, and image phenotype can together determine the need for adrenalectomy in patients with tumors over 4 centimeters. And they recommend multidisciplinary conference. And we do that, and we commonly will see these patients. And again, we all sometimes conclude that, boy, this is a difficult case, and we don't know what to do. So even getting everybody together, no surprise, you at least are doing your best for that individual patient. Now, one comment made here in this article that malignant tumors were less frequently diagnosed incidentally. So that becomes very important. Obviously, things like Cushing's, which are the most common clinical presentation, and many other possibilities, including abdominal pain, weight loss, and the like. And also, compared to all of the studies, larger lesions were again more likely malignant, but again, that alone was not that helpful. Older age, male sex, non-incidental mode of discovery, larger size, and higher non-contrast values, as I mentioned before, were all predictors of malignancy, but that was statistical. Again, still only 1/3 were going to end up being malignant. Now, in this article by Thomas, it's interesting. This article looked at agreement in distinguishing large adenomas from ACC on CT. Our study suggests that CT has the ability to consistently identify characteristics significantly correlated with benign versus malignant lesions. And they did find that CT was indeed helpful, that characteristics associated with benign lesions were round shape, overall radiology impression of benign lesion, presence of fat, making me think of myelolipoma, pre-contrast less than 10. The latter two of these characteristics were highly significant for benign pathology, but that's not surprising because if something measures less than 10, that's our classic definition for an adenoma. And also the presence of fat. Yes, theoretically you can have fat in an ACC, but in those cases, the patient has very aggressive vascular lesion, and typically it's invasion of the periadrenal and perirenal fat. It's not your classic angiomyolipoma or myelolipoma of the adrenal gland. Now, not every myelolipoma, as we know, is going to be fully fat. Some have minimal fat, some have a lot of fat, but people forget that myelolipomas grow. Typically, the problem with myelolipomas is that they can bleed spontaneously, which is why typically most people will agree that an incidental myelolipoma above 5 centimeters will be resected. Now, if we start talking about looking at adrenal masses, and let's try to go through some of them and figure out what we can learn. One thing also you need to be thinking about, and I've seen this mistake many times, and we've all probably have made it, you have to be certain that the mass is really the adrenal. Sometimes pancreatic lesions or splenic lesions or gastric lesions like GIST tumors or retroperitoneal masses can be difficult to distinguish from a primary adrenal mass. And here was a patient who on the lowest images on a chest CT has this large mass, and the computer has a mind of its own, but has this large mass that was felt to be a big adrenal tumor. We brought the patient back, and there's the mass. But if you look very carefully, the mass is actually coming off the stomach. The adrenal gland is seen and is pushed by this mass, and this mass, well-defined, mildly vascular, smooth, and nicely shown in the cinematic rendering, was a GIST tumor. So sometimes gastric GIST tumors can look just like adrenal lesions. Or this case, large cystic lesion with septations, left upper quadrant. You could go through a differential from a retroperitoneal sarcoma to an adrenal tumor, maybe something off the stomach, unlikely, maybe something from the pancreas. This was a mucinous cystic neoplasm, a pretty large one. The septations maybe should have given you a hint, but sometimes lesions, when they're very large, you could see them obviously from across the room, but determining specifically what they are can be more of a challenge. And here again is some more images showing you that lesion. Almost looks like a hydatid cyst, right? Now, in terms of benign adrenal lesions that are large, I mentioned some of this before. Adenoma, cyst, myelolipoma, hemangioma, neurogenic tumors, including things like ganglioneuromas and, of course, hematomas. Here's a 5 centimeter lesion, left adrenal gland. It measures about 20 Hounsfield units. It enhances to about 80 and then washes out, but not as much as one would like. Right adrenal is normal. What could this be? Could it be a pheo that's not very vascular? You can get lab values to prove that. Could it be a MET if the patient had a history of malignancy? Sure. Could it be an atypical ACC by the fact it's small? So it's a challenging case This was resected and was an adenoma. Or this patient, large right adrenal mass. All the differential diagnoses are coming to you. Look at the vascularity around the edge of the lesion. You might also think about hemangiomas. Hemangiomas of the adrenal are rare, but they often do have that kind of peripheral enhancement, very much like a hepatic hemangioma. There's some of the puddling seen on the MIP imaging. The lesion fills in a little bit still. That vascularity is indeed impressive. You'd be going through a differential diagnosis, but I think it's hard in this case to say, oh yeah, this is a benign lesion, let's leave it alone. Patient had some vague symptoms, but the vascularity, again, could think of hemangioma. Could you rule out an ACC with that vascularity? Even a FEO, but of course FEO would have lab values. The answer was no. This was resected and was a 10.5 adrenal cortical adenoma. I would not have picked that diagnosis. It does make the point, and I am learning as well, that adenomas can be really large as 10.5 centimeters. Now, adrenal cysts are easier. Here's a simple incidental right adrenal mass, water density, no enhancement, sometimes a thin septation, no wall thickening, very sharply marginated, an adrenal cyst. Or here's another one, non-contrast CT, large cystic lesion pushing on the liver, pushing on the kidney. So it's not liver and it's not kidney. It must be adrenal. Here it is on the contrast enhanced scan, pushing the kidney down and medial. Here it is, the water content, nicely shown on the cinematic. Here again is the cystic nature of the lesion, very nicely shown on the routine coronal views, and this lesion is almost 20 centimeters. Here it is again on the cinematic rendering. This was a very nice example of an adrenal cyst. Again, very large, but we know cysts can be large. That's true in the kidney, it's true in the pancreas, it's true in the liver, and it's also true in the adrenal gland. Now, another lesion I should comment on is myelolipomas. Myelolipomas contain fat. It may be totally fat or maybe punctate fat. Here's a large lesion with only one zone of macroscopic fat. Some vascularity in the lesion, but you can see the macroscopic fat right there. Again, when I see macroscopic fat, well-defined lesion, I got to be thinking about a lipid-poor myelolipoma, which is what it was. What about this case? This patient has a large mass, right adrenal with a bleed. I don't think you could make a diagnosis. This could be a MET. It could be an underlying ACC. It could be if a patient was on Coumadin or something, but that's unlikely. We would know that. But it could be other things. It could be an adenoma that bled. It could be a myelolipoma that bled. Remember, myelolipomas above 5 cm are typically resected because of the chance of spontaneously bleeding. I don't think we could reach a diagnosis. Now, the patient had no history of malignancy. All the lab values were good. What do you do here? If you look really hard at these delayed images, the venous, it looks like there's something with an enhancing rim sitting right in the middle of the gland, and that was a pheochromocytoma. So with hemorrhage, it can be challenging. What people will say is that if you don't find a cause for the bleeding, then perhaps repeat the scan in about 6 weeks. If you repeat it too early, it's very hard to see an underlying mass. This case might be the exception, and the rim enhancement could have been an ACC as well, but this was a pheochromocytoma after all the lab values were in. And bleeding and rupture of pheo is rare. There's not all that many cases, but it can happen, and it's in that differential diagnosis because these lesions can grow and outgrow their blood supply. Now, let's look at some more cases, but let's do this. We've kind of gone for our limit. Let's take a break right here and come back in 5. See you then. If you like this video, make sure to subscribe to the CTisus YouTube channel. You can also visit us at ctisus.com for even more videos, plus quizzes, pearls, protocols, and oh so much more. We're also in the App Store and have well over a dozen apps for iPhone and iPad, all completely free. Thanks for watching.